I'm an esophagogastric surgeon based at Royal Marsden in London, and I'm going to give you more or less a personal view on some of the information that we've experienced in our journey with enhanced recovery in perhaps one of the most difficult areas in esophagogastric surgery, with also some perspective on the take-home message we picked up on the way. What do I want from my surgical treatment for a patient? To a certain extent, it's self-explanatory. I want to do the right treatment for that patient for the condition they're presenting with. In my circumstances, managing esophagogastric cancer, often in patients who've received preoperative chemotherapy, so they've already got some problems. I want to make that recovery as uncomplicated as at all possible. And I want a comfortable and a confident patient who isn't in hospital very long, but as long as is necessary to recover from the surgery that we undertake, so that the patient is making satisfactory progress throughout their length of stay and into their discharge. And I also want to make sure that the team with whom I'm working, and that's all disciplines, have a good experience and are motivated to maintain the highest possible quality of care. And I think this is where we, in the initial days, and I'll show you why later, in the United Kingdom, the emphasis was very much on reducing lengths of stay. That's the financial bonus from our commissioners and managers' perspective. But I think that the ball has to turn around and we should be looking at the quality of our care in its totality. The bonus is, of course, the patient has fewer complications and there's a shorter length of stay. Now, from the surgeon's point of view, undertaking some of this does actually require some internal reflection, because we're actually going to challenge what is established dogma. We're having to do things which actually are counterintuitive in what we've been brought up in. And I think from the surgeon's point of view, that's actually quite an important aspect that you have to address. Obviously, it's going to be based on evidence. But in fact, when you go to the literature to look for evidence, particularly in my own area, there's very little indeed, and it's very much consensus-based. We were brought up, for example, of doing contrast studies after an esophagectomy to make sure the anastomosis was intact. There is absolutely no evidence that makes a jot of difference, but it made us feel better, because you knew that your joint was sealing satisfactorily. You could still have a leak at 10 days nonetheless. So it meant you had to change the way in which you address the management of your individual patient. I think from the surgeon's point of view, doing the technical side of it, that certainly is something to bear in mind. We set up the process of producing enhanced recovery for esophagogastric cancer about 4 years ago now, which meant a buy-in with everybody involved with the process. And this slide is our approach to what was published in the United Kingdom some 2 or 3 years ago of the pathway. And you'll see it takes in the whole journey from the beginning through to the intraoperative care, through to the discharge of the patient, with highlighting this whole series of different issues which we felt were important in terms of the preoperative assessment. One of the things that we did was to have in the outpatient clinic at the same time as seeing us to discuss their treatment of their cancer, both dietitian and physiotherapist. Physiotherapists would take the patient for a walk, a shuttle walk test, to get an idea of desaturation, for example. We get a full assessment of nutrition from the nutritionist, and that was repeated when the patient came back after they'd undergone their neoadjuvant chemotherapy. A small thing, but it fits with service improvement. You just make a little change, it makes an enormous difference. And those little changes were implemented throughout this pathway. One of the things I teach my trainees is those first two questions, because we can certainly stage patients with esophagogastric cancer and with lots of cancers to understand whether the patient's tumour is treatable. But you've got to make sure that the patient who has that tumour is equally treatable because of their comorbidity. And that focuses the mind on patient-centred care. You can have a multidisciplinary team discussion about the staging of particular malignancy. But if that patient has significant comorbidity, which you may find some difficulty in correcting, you may have to revisit your treatment options. So it's making sure that the optimisation preoperatively is done as best as possible, which means addressing the comorbidity the patient has. And these comorbidity issues, I think, are crucial. I've already indicated how we try and address some of the respiratory issues, but a key here, particularly for what we do, is making sure that cardiovascular and respiratory comorbidities are addressed. But we have to make sure we've addressed the nutrition situation. And again, with the sorts of cancer I'm dealing with, that's a significant problem for many such patients. The issue of surgical site infection is as old as surgery. We have to make sure we've considered that, and not only surgical site infection, but the sorts of things that the comorbidity can induce with it. And it's addressing those, and hence from the respiratory point of view, where the physiotherapy comes in. The intraoperative side of it, from my point of view, is crucial. I have to do the best possible operation I can with a very close team working relationship with my anaesthetic colleague and subsequently with the intensivist who look after the patient post-operatively. I know that I have to produce an operation that is removing all possible sites of disease, and this goes back some years as to what was prescribed for us surgeons to have to do, and indeed it's probably pertinent to any cancer operation. You are trying to remove all possible sites of disease so that the patient is as near cured as you can make it. And I know also where I have my role. This is information for gastric cancer. We're on the left-hand side of the interventions that endoscopy can do. It's the bit in the middle, the radical gastrectomy, which is surgeon dependent. It depends upon me undertaking the most appropriate operation with the extent of nodal dissection as we've defined it in various guidance to give the patient the best opportunity. So that's the surgeon's role, and it's not only the case of doing the resection, but it's also the anastomosis that is crucial. So from my point of view of outcomes, I have to make sure I've got those as technically perfect as I possibly can. And there are guidelines. There's lots of guidelines. We've been talking a little bit earlier in the executive group about how we develop guidelines, and each country will have separate guidelines. This is just a snapshot of what's available in Europe for what we should be doing surgically. And so it's important that we make sure for consistency and that the standard of care is maintained, and hence the use of surgical guidelines. That's why I think it's so important to develop the enhanced recovery-based guidelines so that we are all doing the same process to get the best outcome. I think some of the things that have cropped up from my experience with enhanced recovery are very much the approach post-operatively. We used to delay feeding deliberately because of this protecting of the anastomosis. We used to be very concerned, and still are, about controlling the inflammatory response, and we'll hear a lot more about the physiology of that later. And the other issue is getting the patient up and moving. Don Lowe, who's the doyen of upper GI enhanced recovery, makes the point that these patients have actually walked into hospital. They've not come in on an ambulance unwell as emergencies, so why shouldn't they be walking the very next day they've had this sort of surgery, or even the evening if you can get your cases done in a decent time? And that level of mobilisation means you're getting normal physiology going as quickly as possible. Just some information from our own experience when we introduced it. The top half of the slides showed what we were doing with the phase of what our normal practice was. The single simplest thing we did was to drop doing the contrast study for esophageal and gastric anastomoses at 5 days. It meant the patients were drinking at 48 hours. We took 3 days off the length of study. But we did hit a little bit of an impasse, but we got as far as we possibly could, and hence the similar information, the data you got there for the 2011-2012 means that the lengths of stay hadn't really shifted that much. But the argument is, our probability is that the quality of our care had improved. We've looked at the complications, and we haven't yet got to the stage looking at complication improvement. But the issues that we came across, particularly for the Clavian 2s, were pulmonary. And it's identified the need that in the workup from the physiotherapy point of view, that they concentrate on adequate physiotherapy programs to improve respiratory hazard. And this is what we've been talking about. How good are we? This is a rough and ready slide of what we've tried to do with our own practice. There's a poster with this next door. Our discussion with the patient and the pre-op information that we give with the carbohydrate loading has been pretty effective. But what's interesting is the early immobilisation. We can do it for someone who's had a gastrectomy, but we know we've had problems trying to get patients mobilised after an esophagectomy. So that's where we've got to try and reinforce the message to the team to develop the approach that we've put in place. And this is crucial. Again, Poster next door's got this. My colleagues from nutrition and from physiotherapy have formulated the patient feedback. It's interesting to see what patients interpret. Slightly concerning about the patient on knowledge and understanding of enhanced recovery was unsure. We didn't get that message across. And also there's one patient there who was not quite sure what operation he was having. Again, slightly concerning, perhaps again not getting the message across. But the second half of the slide shows what we were doing with discharge preparation, who to contact if they had problems, when were they coming back to outpatients. And it's this buy-in of the patient as the whole route of the pathway, why it should be patient-centred. So I think this is a crucial component of what we should be doing. There are outside influences. In the United Kingdom last year, the NHS England, which had come into being in April 2013, made the edict that of the 10 nationally funded audits, individual surgeons' outcomes should be published by name. The problem with that is that we have had national audit of esophagogastric cancer for 5 years. It's self-reported, it's not mandatory. So there's some doubt or some question mark about the reliability and whether or not it's risk adjusted. If you come out poorly, are you going to no longer do operations on patients who are higher risk? You become risk averse. But it does stimulate personal reflection, and this is what was published. This is my own institution, with a funnel plot showing the main bar just above the x-axis, which is the mean, with a green dot, so we're okay. There were some concerns being raised about the 3 dots just under the funnel plot. We made it deliberate that we were trying to keep this as the crude data last year because we were concerned about risk adjustment. But that is in the public domain. That has my name on it and my 3 colleagues in my institution. As it does for every other 28 of the centres in the UK, you can identify your surgeon by their activity. So we have to get it right from the point of view of what we're doing. It does put a bit of extra pressure on us as surgeons.